Okay. Bonjour tout le monde. Hello everyone, please take a seat. Bonjour tout le monde. Je m'appelle Eve Dubé, je suis anthropologue et je suis la présidente de VARN. For colleagues who don't speak French, no worries if you didn't get your automatic translator in the back. I will say more or less the same thing in both languages. Donc, ça me fait grand plaisir de vous souhaiter la bienvenue à cette deuxième conférence du réseau d'acceptation des vaccins, la première en personne. Je tiens à vous remercier pour tous les efforts que vous avez faits pour venir ici. Je sais que c'était parfois un peu compliqué avec les visas, mais bienvenue. On a un agenda assez rempli et une plénière avec beaucoup d'invités intéressants, donc je ne vais pas prendre trop de temps pour les remarques de bienvenue, mais je tiens à remercier le Sabin Vaccine Institute et UNICEF pour nous accueillir aujourd'hui et aussi Gavi qui a financé la conférence. So I am Eve Dubé. I'm a medical anthropologist. I'm based in Quebec City, and I do work on vaccine acceptance, and I'm the VARN chair. So it's with great pleasure that I welcome you to this second VARN conference, first in person. I want to thank you all for the efforts you made in coming here. I know it was challenging for many of you, so welcome. We have a packed agenda and a very nice plenary to kick us off, so I won't take too many times in introducing remarks. I just want to let you know that the latest version of the agenda is available using your QR code. So, pour les collègues, la dernière version du programme, il y a eu quelques changements, donc la dernière version du programme est disponible en scannant le code QR. I want to thank the Sabin Vaccine Institute and UNICEF for hosting us, and also Gavi who co-sponsored this event. To start, we will have two videos, and I'll introduce the speakers. So first, we will hear from Mayo, the UNICEF East Asia and Pacific Regional Office Deputy Regional Director at UNICEF. Mayo has more than 22 years of experience with UNICEF in different positions, including as various deputy representative. He worked in UNICEF country office in Laos, Namibia, Tanzania, Myanmar, and UNICEF regional office for South Asia in Kathmandu, Nepal. Prior to joining UNICEF, Mayo worked with international NGOs, Save the Children, and Médecins du Monde. And then we will hear from Alex de Jonquière. Alex de Jonquière is the Director of Health System Strengthening at Gavi, the Vaccine Alliance, and has been with Gavi for over 10 years, formerly as the Chief of Staff. So video supposed to be shown on this video.
Good morning, distinguished participants, ladies and gentlemen. On behalf of UNICEF East Asia and the Pacific, I'm pleased to welcome you to Bangkok and to this exciting conference on vaccine acceptance. Let me begin by thanking the Sabin Vaccine Institute, Vaccination Acceptance Research Network, for hosting its second annual conference, co-convened with UNICEF and co-sponsored by Gavi, the Vaccine Alliance. May I take this opportunity to share a few thoughts on the first core theme of the conference, vaccine equity. I'm reminded of a recent project we undertook on zero-dose communities and zero-dose children in the East Asia and the Pacific. Not surprisingly, we found that zero-dose children are often the very same child who are also missing out on many other essential services across the health sector and beyond. It is important to acknowledge that the communities characterized as having these multiple deprivations existed long before the COVID-19 pandemic, though the pandemic exposed those vulnerabilities. This emphasizes the need to rethink and reinvent our work as needed to better reach communities disconnected from the formal systems and services. We simply cannot and should not continue with the same approaches, to implement the same programs in the same ways, to pose the same research question using the same research method, and expect to see different results. As important gains have been made on the supply and distribution side, it is timely that we are here to recommit our efforts on the vaccine acceptance dimension, the demand side. Vaccine demand has been increasingly challenged both by the COVID-19 pandemic and the explosion of misinformation, thus requiring continued innovative approaches and sharing of experiences. This is an opportunity to share and apply our lessons from the pandemic to strengthen both routine immunization and primary healthcare services. As this conference begins, my plea to each of you for two considerations. One, let us be open-minded to share and learn from each other. Two, identify opportunities for collaboration and innovation. It is through collaboration and collective action that we can address the inequities in immunization. These lessons will be relevant far beyond immunization in the health sector, having long-lasting implications for families and children globally. I wish you a fruitful conference and look forward to our continued efforts to work to improve the health and well-being of every child. Thank you very much.
My name is Alex de Jonquière. I'm the Director of Health System Strengthening for Gavi, the Vaccine Alliance. I'm sorry I can't be there with you in person today due to our competing midterm review in Madrid this week, but I'm looking forward to hearing the outcomes of your really important discussions. For those of you who don't know Gavi, and I suspect most of you do, we are a public-private partnership whose mission is to save people's lives and improve people's health through the equitable use of vaccines. Since 2000, Gavi has helped support countries to immunize over 1 billion children, and in the process we've helped to avert 16 million future deaths. Our strategy for 2021 to 2025 has equity as its focus, with a focus on ensuring that we reach the 12.5 million children who are currently missed every year and who do not receive a single dose of routine vaccines. Delivering on equity will require us to think differently. It will require us to really understand why the many children, adolescents, and others who are missed by immunisation services at the moment are missed, and how we tailor services going forward to reach them. It will also require us to think differently and really focus on demand, an area which, as an immunisation community, we have not focused on sufficiently since Gavi was founded in 2000. For too long, we've assumed that if we just strengthen services, that children will get immunised, and we know today that it's far more complex than that. Moreover, the COVID-19 pandemic has significantly impacted demand for vaccination and led to the spread of misinformation. Certainly in high and middle-income countries, recent surveys show that there has been a worrying dip in acceptance of vaccines, and this is a trend that we need to arrest rapidly and immediately. Doing so will require renewed investment in demand, but also new approaches and innovations to generate demand and build confidence in communities. Now is also an exciting time in immunisation, with many new vaccines coming available at different times across the life course to protect different populations. And it's therefore important that we take stock of how we help to build vaccine confidence and demand among broader sets of the population than we've thought about historically. The human papilloma vaccine program is a great example of a new vaccine with the potential to save millions of lives, but also the complexity that comes in terms of strengthening service delivery and generating demand among new populations. We've seen as Gavi this challenge in real time, and while we are committed to supporting countries to immunize 86 million girls with HPV by 2025, we know, and experience to date shows, this is going to require new ways of working, new ways of thinking, and new ways of engaging with communities. So what is needed? Firstly, we need to collectively accelerate the use and scale up of the new and innovative tools that already exist and we know work. Gavi is doing its part. We are working with countries to significantly increase our investment in demand. In 2022, we're seeing 4 times more funding going into demand than was the case in our last strategic period between 2016 and 2020. We're also seeing countries make greater use of innovative tools and approaches, such as in India, for example, where they used behavioral insights and new social data and human-centered design to design much more effective demand interventions. But we need to do more collectively. Too much of the funding that Gavi provides is still going into more traditional business-as-usual approaches, printing posters, radio slots, T-shirts, and these are important. But we know they alone are not sufficient to generate demand, overcome hesitancy, and really engage communities. So we collectively need to do a better job of supporting countries to design stronger interventions and make the best use of the funding that is available to generate demand for immunization. Secondly, we need more research into what really works for demand. Through Gavi's strategic focus area investments, we are working with partners to test and pilot new approaches to demand generation. This year, for example, we will be testing the use of demand-side incentives in countries including DRC, Cameroon and Niger. And we're also going to be launching an RFP shortly to understand how we could use the care group approach and social accountability models to strengthen delivery of immunization and demand for immunization services. Thirdly, we need to remember the key role that women play in immunization, both as caregivers and as service providers. No immunization program is going to be successful in reaching every child unless it's designed to meet the needs and address the barriers that women face in both delivering and accessing immunization services. And lastly, we need to bring together demand-side insights on what communities need and want from their services with the planning and delivery of immunization services themselves. For too long, service delivery planning and demand generation have been separate discussions, and increasingly they need to be brought together and integrated to ensure that we tailor immunization services to meet the needs of the communities they serve. Those of you who work in demand and community engagement, which includes everyone in this room, knows that this is not just a technical area. Generating demand, building community confidence, requires us to peer deep inside the communities we serve, understand their needs, their desires, and the barriers that stand between them and ensuring long, healthy lives for their children. Those barriers are barriers we can address, and we can address together. But doing so requires us to ensure we understand them, that we take those insights to use to inform how we plan our services and our programs, and that we continually learn together to continue to reach the most marginalized and those who have been systematically missed by programs. I wish you great discussions over the coming days and look forward to hearing the outcomes of your conference.
Donc, c'est maintenant avec grand plaisir que je vais introduire la Dr. Anuradha Gupta for opening remarks. So, Anuradha Gupta is the president of Global Immunization at the Sabin Vaccine Institute. A veteran public health leader, Ms. Gupta has, in her previous role, spearheaded a host of successful global initiatives to improve the health of women and children and harness the full power of vaccines. Her work has created a profound impact at a global scale in improving and saving lives of children. Prior to Sabin, Ms. Gupta spent several years at Gavi, the Vaccine Alliance, as its deputy CEO, where she pioneered the concept of zero-dose children, focusing on children who have not received even a single dose of the most basic vaccine. She also led efforts to roll out a new framework for country-centric engagement immunization strategy with remarkable success. Before her time at Gavi, Anuradha served as a mission director at National Health Mission of India, where she ran the largest public health program in the world and played a leading role in the country's effort to eradicate polio, reduce maternal and child mortality, and revitalize healthcare. Anuradha holds a Master of Business Administration from the University of Wollongong in Australia. So welcome, Anuradha.
Good morning, everyone. It's so wonderful to see all of you, see this room full of energy. And I do want to open my presentation with a quote from Mahatma Gandhi that always inspires me a lot. He said, "A small body of determined spirits fired by an unquenchable faith in their mission can alter the course of history." And I do believe that this VARN community, with its 400 plus members, with their curiosity, with their humility, with their passion, with their self-belief, can truly ensure that every child everywhere benefits from the full power of vaccines. Sadly, that is not the case today. And why is equity in immunization an imperative? Because even today, far too many lives depend on vaccines. For millions of children, it still continues to be a matter of life and death. And I did want to share Nelson Mandela's powerful quote with you. And these are the words that he used in 2003 as the first chair of Gavi board. And Gavi was very young at that time. And he actually drew the global attention to the inequities that existed at that time in terms of access to life-saving vaccines. And as a result, millions and millions of children were dying unnecessarily because of diseases that could be so easily prevented with vaccines. The situation today has changed. And let's look at 2023. The vaccines now are available, but vaccination is becoming a challenge. And vaccines, unless converted into vaccination, of course, cannot save lives. And here we all are aware of the kind of questions, doubts, mistrust that we saw on the part of communities during COVID-19 pandemic. And that indeed is the challenge which I'm sure is going to be discussed at length during this 3-day conference. Unfortunately and worryingly, immunization progress is moving in the wrong direction. We are seeing fewer and fewer children getting vaccinated. As a result, as I said, we are not averting as many deaths as we can, by making sure vaccines reach everybody everywhere. We know that nearly 20% of children every year remain deprived of even the most basic DTP vaccines full course. And what is extremely disheartening is that during the pandemic, we actually witnessed a 37% increase in the number of zero-dose children who do not receive even a single vaccine shot through routine immunization services. Now we know that since the inception of Gavi during the last 2 decades, breadth of protection has increased. More children in lower middle income countries have started to benefit from the protection of more vaccines. However, there are millions of children who have remained consistently deprived of the benefit of even the most basic vaccines, as you know, and as I said earlier. And the pandemic really pushed the number of these children higher. And in 2021, we had 18 million children born that year who did not receive even the first dose of DTP. Not to forget that in 5 years, you multiply this by 5, you multiply this by 10, and you really start to get an understanding of the accumulation of zero-dose children that we are seeing. And as public health experts, you know what are the consequences of accumulating millions and millions of zero-dose children. 62% of these zero-dose children actually live in just 10 countries. And all of us understand that India, Pakistan, Ethiopia, DRC, Nigeria are large populous countries. So in a country like India, where vaccination rates really have gone up, you still have a large number of zero-dose children, 2.7 million, because their annual birth cohort itself is 26 million every year. But we also see in this category new additions. So you see Myanmar, that suffered from political instability and political turmoil, doing extremely well before the conflict, but now it sits in the top 10 countries with the largest number of zero-dose children. We see Brazil, we see Philippines, we see Angola. So countries, and which really is a reminder that countries that might be doing quite well can actually start to see a slippage of immunization. So here there is no resting on our laurels, but also to remember that many countries are there which may have smaller birth cohorts, not as large as India, Nigeria, Ethiopia, but they have very high proportion of zero-dose children because of low vaccination coverage rates. Look at PNG, Papua New Guinea, where more than 60% of children actually are zero-dose. And you see here Angola and Myanmar, where you have in absolute terms, very large number of children who are zero-dose, but as a proportion also, you have very large number of zero-dose children. So in some of these countries, we see a situation that actually is probably waiting to erupt into large-scale disease outbreaks and also preventable child mortality. Now, where do these children live? And as Alex said, we did a lot of digging on this, and I actually had created this concept of zero-dose children because many of you are aware that historically the third dose of DTP was the proxy indicator for measuring access to immunization. But when at Gavi we started to focus a lot on coverage and equity of immunization way back in 2015, that is the time when I realized that 2/3 of those children who do not receive the third dose of DTP vaccine actually do not receive even the first dose of DTP. And that is how the whole concept of zero-dose children was brought forward. And when we started to understand the phenomenon of zero-dose much more in collaboration with UNICEF and our other partners at the Equity Reference Group, we realized that nearly 50% of these zero-dose children live in certain specific contexts, urban poor. And we know that there is rapid urbanization. In fact, there are projections that suggest that by 2050, Africa's urban population would increase threefold. And in Asia, there would be 61% increase in the number of people who are living in urban areas. And by 2050, 73% of people in urban areas would reside only in Africa and Asia. So you see this mushrooming growth of the urban poor, and we've often seen that a lot of these urban slums, which involve a lot of informal settlements, actually have pretty much no service delivery or no coverage at all. So you really find a large concentration of zero-dose children increasingly among the urban poor. And of course, our Achilles heel, which is remote and rural areas, that is why we always talk of hardest to reach, inaccessible, remote areas. But now children are living right under the nose of the governments in urban slums, right? So when I went to Nairobi, Kibera, which is one of the largest slums, actually is just about a kilometer away from the parliament in Kenya. So these children are right under our nose, right in front of our eyes, and yet they are zero-dose. But we also have nomadic populations, mobile populations, where we've traditionally faced a lot of challenges of service delivery. And the last is the displacement that is being caused by conflicts climate shocks, food shortages. Now, the latest projections suggest there are 103 million people who have had to flee their homes. And clearly, these are families, households, people, children who are losing access to services. And as the Deputy Regional Director of UNICEF emphasized, we require new solutions, new approaches. The kind of solutions that are required to reach the urban poor are not the kind of solutions that are going to work for nomadic populations. And just to share my own experience with you, when I was at Gavi and we started to look at challenges, of urban immunization among the poor, what we found was that even changing the time of the immunization session to late evening or offering immunization services over the weekend actually enabled a lot of working women, to bring their children for immunization, and the vaccination rates began to go up. That happened in Dakar in Senegal, in Haiti, and several other countries. So there is low-hanging fruit if we only push ourselves to start to think differently, so that we start to really think about whether we can design and deliver immunization services somewhat differently than what we have done in the past. And when in Chad, I had gone on a mission to Chad and had a meeting with the president of Chad, and we talked about the challenges among nomadic populations. At that time, the vaccination coverage rate among nomads in Chad was 2%. And then there was a delivery mechanism that was designed, which actually brought their livestock vaccination and children vaccination together. Some of the people may actually find it funny, right? Saying whether children are, if we want to get into that didactic debate, whether children have the same value as the lives of cattle. But yes, the cattle are important to these nomadic populations because they are their primary means of subsistence. And we saw that when these services were co-delivered, again, vaccination rates shot up. And Chad is one country, when I visited Chad in 2015, it had 42% coverage. Today it is 58% coverage. During the pandemic, Chad did not look back and actually maintained its upward trajectory. So we really need to be more creative. Displaced populations, we found there are children, cross-border settings where they're falling through the cracks. But also in many countries under active conflict, we needed to really negotiate peace corridors with the help of UNICEF and a lot of other humanitarian actors. So really thinking about what are the new partners and new actors that we haven't worked with in the past who might actually play a role here. I also want to just highlight that when we are talking about 50% children living in those specific contexts, we should not be oblivious to the fact that about 50% of the children, zero-dose children, live in non-specific contexts. They are all over, right? So how many villages in any country can actually boast of 100% vaccination? Hardly any. So you go to any town, city, village, you would have a few households where children are not getting vaccinated or are getting partially vaccinated. And what are the essential barriers? So one is poverty. And we found that 2/3 of zero-dose children actually live in households that subsist on less than $1.90 per day, which is the international definition of extreme poverty. And we also know that as a result of the pandemic, 97 million more people have been pushed into extreme poverty. So our challenge has become even bigger. So looking at the poorest households that are unable to avail of the services, which may be there or maybe they're to an inadequate extent. Gender, and we keep on talking about gender, we also find that, women education plays a very important role, and also women empowerment plays a role. And during the pandemic, both took a hit. So therefore, again, that challenge has become bigger going forward. Ethnicity, we found religious minorities, ethnic minorities, which really feel persecuted, are also the ones that typically have low utilization of services. So here, this is very interesting sort of data from Afghanistan, where you can see that there is one ethnic group, Turkoman, which has very high vaccination coverage with very few zero-dose children. But on the other end, you have Nuristani ethnic minority, which has such a large number of zero-dose children because of the stigma, the neglect, the exclusion that they typically face. Now, zero-dose children, and I was so pleased to hear the Deputy Regional Director of UNICEF say that. And, this is something that we were able to establish based on a lot of data mining and data collation, that these zero-dose children are actually symbols of multiple inequities, multiple deprivations, and compounded vulnerability. Because we found that a lot of times the mothers of these children are unable to access reproductive health services, including skilled birth attendance, antenatal care, and a lot of times these households do not have access to water, sanitation, nutrition, children are not in schools. Why is it not just a moral imperative, but a public health imperative to reach these children? Because though only 1 in 10 children was zero dose prior to the pandemic, 50% of vaccine-preventable deaths are concentrated among zero-dose children. So if we really want to save lives, then these are the children that we absolutely have to identify and reach. And as I said, the peril of not reaching zero-dose children is grave, because you would just have these concentrations and clusters of zero-dose children, and suddenly they become epicenters of disease outbreaks, and a lot of mortality. And now with this whole backsliding of immunization coverage, it is not just measles that we are seeing. We are seeing an epidemic of circulating vaccine-derived poliovirus, but we are also seeing diphtheria cases despite very weak surveillance across countries. So really a warning sign for all of us. So this is something that I always like to highlight. Why is it important to reach the zero-dose child? Because once you reach a child with just one vaccine shot through your routine immunization delivery systems, 2/3 of them actually go on to receive more vaccines. And as was just said, also several other services. So how do we make sure that immunization actually becomes that rallying point, through which a lot of other primary healthcare services can be delivered to zero-dose children and their families? So let me now turn attention to life course immunization, because now we know the pandemic threw two things in stark relief: the issue of equity, but also the issue of life course immunization. Today, we are not looking at just childhood vaccines. There are vaccines for adolescents, for adults, and we are now seeing inequities that are less understood. And HPV vaccine, to my mind, is a prime example. The vaccine was approved way back in 2006, and yet today, the global coverage of young girls with 2 doses is stalled below 15%. Actually, it is 12%. And we have seen at the same time that cervical cancer deaths are going up from less than 185,000 in 1990 to now 340,000 per year. And unfortunately, 90% of these cervical cancer deaths occur in lower and middle-income countries. And of course, Africa is having to struggle with multiple disease whammy, they with HIV and TB, and we have evidence gaps there. We don't fully understand how many HPV vaccine doses are going to make sense for some of these immunocompromised, immunosuppressed populations. And SAGE guidance, I must highlight, does not speak about non-binary population groups. What about transgender individuals who are going to be at high risk? So we need to all come together in order to really start to shine spotlight on some of these groups and communities which have long been marginalized and neglected. When we started to unpack cervical cancer, and Sabin just launched a global HPV consortium. We would be leading a collective of public-private sector partners, and it's a call to all of you to come join us. It's a nascent initiative. We saw that poverty does remain a strong predictor of inequities at both country and household levels. In fact, I was very struck by the fact that age-specific incidence rates for cervical cancer in Africa are the highest. So absolute numbers may be low because the population is smaller, compared to Asia, but really and you see that here, that strong link between income and cervical cancer incidence. Education plays a role, right? So you can see that those families where education level is lower, you have higher cervical cancer rates. And then we saw that COVID-19 vaccines often fail to reach the elderly despite high vulnerability. And you can see that it was low-income countries that had a particular challenge because live course vaccination in many of these countries actually hasn't really begun. So there is maternal immunization to some extent, but beyond childhood immunization and the TT vaccine for maternal immunization, there isn't really pretty much anything else. So really are an area for us to pay attention to. And then, of course, the marginalized communities. So zero-dose children, when we're looking at children, are a very powerful symbol, as I said. But then we also, when we get into live course vaccination, we see that there are marginalized communities that really have had a long history of negative experiences within the healthcare system. And this is really wonderful, wonderful research that has been carried out by Sangat, with the funding that Sabin was able to provide, where they try to understand the barriers that transgender individuals and people with disabilities face during COVID-19 vaccination. And you can see here that there hasn't been any attention paid to some of the unique needs that non-binary groups have. And then, of course, the imperative of making vaccine services human-centered. A lot of us are using this word, human-centered design, right? And absolutely that is the right way to go. But, we use language, but then how is that being implemented? And here you see, right, that even the simple, most basic things are missing. If you don't have a ramp for people with disabilities, if there is no place for mothers to sit, there is no shade, there is no provision for water, service providers' attitudes are not courteous and compassionate. So a lot of these factors at play here. Low-hanging fruit, this is not difficult to fix. We can all fix it. As I said, you can play a role. You have the power to change this, and that's the whole purpose of having this conference. Thank you very much for your attention.
Thanks, Anuradha, for this very inspiring opening remarks. And now I will welcome the speakers for the plenary session. Bear with me with my French-Canadian reading of the bios, very impressive bios. So our first panelist is Deepa Risal Pokharel. Deepa is the Senior Advisor, Social Behavior Change and Team Lead for Immunization Demand in UNICEF headquarters in New York. She has over 25 years of diverse experience in designing, leading, managing and implementing social and behavioral change communication, strategies and intervention at national, regional, and global level. Deepa has represented UNICEF in various global and regional forums to promote vaccine demand and community engagement. Before joining New York headquarters, Deepa worked in UNICEF Pakistan, UNICEF Regional Office in Nairobi, UNICEF Zambia, and UNICEF Nepal in different capacities, working in immunization, health, and broader social and behavioral change on child survival, development, and protection. She is a believer in people, positive strength, and power of team to make things work. Welcome, Deepa. So the next panelist is Dr. Sangwe Clovis. Dr. Sangwe is a public health physician and researcher with extensive experience in healthcare access and community health system strengthening in low-resource settings. His role is in generating and implementing innovative approach to enhancing health equity and sharing lessons in national and international platform. It's reflected in over 10 high-impact multi-stakeholder intervention and action research he has led in underserved settings. He is initiative as an associate routine immunization and MIS community. He is also part of several national and international movements to enhance health equity in low-resource settings, such as the Long-Acting Technology Community Advisory Board, TAG AfroCab. The next panelist will be joining remotely. Saad Omer is currently the Dean of and Professor at the University of Texas Southern O'Donnell School of Public Health and has conducted studies in the United States, Guatemala, Kenya, Uganda, Ethiopia, India, Pakistan, Bangladesh, South Africa, and Australia. Dr. Omer research portfolio includes epidemiology of respiratory virus, such as influenza, RSV, and more recently COVID-19, clinical trials to estimate efficacy of maternal and infant influenza, pertussis, polio, measles, and pneumococcal vaccines, and trials to evaluate drug regimen to reduce mother-to-child transmission of HIV. Moreover, he has conducted several studies on intervention to increase immunization coverage and acceptance. Dr. Omer's work has been cited in global and country-specific policy recommendations and has informed clinical practice and health legislation in several countries. He has directly mentored over 100 junior faculty, clinical, and research postdoctoral fellow, and PhD and other graduate students. Dr. Omer has published widely in peer-reviewed journals, including the New England Journal of Medicine, JAMA, Lancet, British Medical Journal, Pediatrics, American Journal of Public Health, Science, and Nature, and is the author of op-eds for publications such as the New York Times, Politico, and the Washington Post. Dr. Omer has received multiple awards, including the Maurice Hillman Award by the National Foundation of Infectious Disease for his work on the impact of maternal immunization on respiratory illness in infants younger than 6 months, for whom there's no vaccine. He has served on several advisory panels, including the U.S. National Vaccine Advisory Committee, Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria, Vaccine Innovation Working Group, and WHO Expert Advisory Group for Healthcare Worker Vaccination. He also served as an academic affiliate of the Office of Evaluation Science, formerly known as the White House Social and Behavioral Science Team. So welcome, Saad. The next panelist is Lillyan Mutua. Lillyan works for Nairobi City County Government Health Service, Kenya. She's the head of health promotion, in charge of advocacy, risk communication, community engagement, public literacy, health communication for health service in Nairobi. She has been instrumental in delivering strategic social behavior strategies during the COVID-19 pandemic, COVID-19 vaccination, HPV, polio, and measles campaign. She's passionate, committed, and focused to implement health promotion models to empower citizens and to make informed decisions toward improving their quality of health. She attributes her zeal to cross-country learning and sharing forum and the invaluable knowledge from the expert mentors who she has come across in her line of duty. She aspires to make communities better since her first appointment as a community nurse in the rural Kitui in the early 90s. Lily believes there's an opportunity to use digital space and social media to promptly inform and educate community. School-going children and women should be used as agents of behavior change in households and community. She believes Embracing health promotion and preventive promotive health is the way to eradicate immunization, prevent disease, and prevent epidemic. And the last panelist is Dr. Glenda Gray, an NRF A1 rated scientist, CEO and president of the South African Medical Research Council. Professor Glenda Gray is a qualified pediatrician and co-founder of the internationally recognized perinatal HIV research unit in Soweto, South Africa. Prior to her appointment at the South African Medical Research Council, she was the executive director of the perinatal HIV research unit, an affiliate of Wits University. Glenda global profiles includes a role as co-PI of the HIV Vaccine Trials Network, an international collaboration for the development of HIV/AIDS prevention vaccines. As the COVID-19 pandemic developed, she was among the first to lead the public discourse on the issue and to move quickly to establish COVID-19 vaccine trials in South Africa, utilizing the experience and network developed over the years for the HIV vaccine work. Glenda serves as a protocol co-chair of the multi-country ensemble study investigating the single-dose COVID-19 vaccine as an emergency response intervention. She received South Africa's highest honor, the Order of Mapungubwe, for pioneer research in PMTCT. Other prestigious accolades include the Nelson Mandela AIDS and Human Rights Award for significant contribution to the field of mother-to-child transmission of HIV. Thank you.
So thank you, Dr. Can you hear me? Can you hear me? Yes. Okay. All right. So great. So you just heard the bios of the panel members. We have here a very, very illustrious set of panelists. And let me sort of turn to Deepa first. And Deepa, as has just been shared with you all, is really UNICEF's lead on vaccine demand, but really also social and behavioral science and the role that it plays in vaccine acceptance and demand issues. So really, Deepa, the UNICEF report is just out on the status of the children of the world. This time it was focused on immunization. You have done a lot of deep digging around some of the issues, and that report also highlights that the confidence of communities in vaccines is actually sort of dipping. And would you be able to share with the audience here what really are the key issues that you see as important, and what are the priorities for UNICEF going forward?
Can you hear me? Thanks, Anuradha. First of all, very happy to be here, co-sponsoring the VARN event with Sabin, and so happy to see so many. The power of vaccine is so obvious because we all are here. So, as you said, the State of the World Children was just released. The State of the World Children is a flagship report of UNICEF. It is released every 1 to 2 years and in different thematic areas. And this time, as you said, it was on immunization. So the report has highlighted a couple of things. Of course, in your presentation, you already talked about the zero dose, the number of zero dose children going up. We've seen the biggest decline in the past 30 years in immunization coverage. But what it has also seen, has also revealed from a data that was collected by the Vaccine Confidence Project, is there are some concerns of dipping in terms of vaccine confidence. Of the 55 countries which were looked at, surveyed over a period of quite a long period, from 15 to 22, excluding 20, it has indeed shown that the confidence in vaccine is dipping. However, we also have to note that the vaccine confidence is very volatile and context specific, right? So yes, of course, it is an alert, it is a concern. concern, which also means that we need to dig more in terms of research to find out what is it that is really preventing our parents from taking the children for immunization. What is the fears, or is it just because of COVID-19, or is it something else? Is it access? Is it affordability? So I think we have looked at a few things, like the coverage is one thing, of course, but the second part is the vaccine confidence. It might be that the supplies for the routine vaccinations may have been missed during the COVID-19. So there is a lot to do in terms of vaccine confidence. But when you ask me about the priorities, I think there are a few things that the countries are trying to put together. The first being the catch-up. The essential routine immunization recovery plan is going to be really, really important as countries try to restore the immunization levels to at least to 2019. So the essential recovery plan has three components: basically catch-up, restoration, and the primary healthcare. So for us as UNICEF, which supports the government across more than 130 program countries that we support, we have been working very closely together with WHO, Gavi, our other partners, to make sure that we are supporting the governments on this catch-up, because it's going to be very important to catch these children who may have been missed out. And normally, as we know, the cohort for children is under 2. But during the pandemic, there is no way that to track the data on where these children are. So through the catch-up and recovery plans, the children would be able to, we will be able to bring the loss that we've seen in the past 3 years and recover at least to the level of 2019. And then the pandemic has also taught us that how important it is to strengthen the primary healthcare system, because all the gains that we've made during the COVID-19 in terms of system strengthening, the cold chain, the community systems, the surveillance, the data system, these needs to be really leveraged and repurposed to strengthen the routine immunization, so that at the end of the day, you know, we have strong, resilient health system to be able to address any possible pandemic or disease outbreak, because we've seen so many outbreaks of diseases in the pandemic that we do need to talk on. And the last thing I would want to say, there are resources out there. Saad is sitting right in front of me, even though not physically here, but the team, Saad's team had worked on the I Vaccinate booklet, is really has looked at what could be some of the evidence that we have seen, which could guide us for recommending these are the few interventions which seems to have worked. And they've done a wonderful work of looking at more than 15,000 different interventions and have come up with recommendations. Another good example is the little jab book, which was developed by Save the Children, Busara, UNICEF, which looks at what could be some of the interventions that you could take for. Lastly, I would stop by saying that it's so important to talk about the gender issues, because if we are not able to look at immunization and gender together, I think that the last mile that we are trying to reach, even after the recovery, is going to be very difficult. Let me stop there.
So thank you, Deepa, for those wonderful reflections. So let me turn to you, Dr. Sangwe Clovis, and sort of ask you for your perspective on two things that Deepa highlighted. One was this whole issue of catching up. So there is a lot of emphasis now on catching up children, right? So there were certain children who were missed during the pandemic. How do you catch up, and how do you restore coverage to pre-pandemic level? But then there is also the issue of taking it beyond that, because we know that even before the pandemic, you know, the immunization progress had stalled, and there were children who were unvaccinated or under-vaccinated. And your own work actually has focused a great deal on those children. So what are the factors that need to be kept in view when catch-up strategies are designed, you know, on the ground in a manner that it does both catch-up of children but also benefits, you know, routine immunization longer term?
Thank you very much. It's really a pleasure to be on this global stage to have this conversation. The issue of catch-up is very interesting, but we have to note that things have changed. The landscape when it comes to vaccination has changed enormously. And so the routine use of campaigns and repeated outreaches, in my opinion, doesn't work. To a certain extent, it has lots of limitation. It fuels more hesitancy. It creates a vicious cycle in the field. This is what happens. You go into a community, there is already hesitancy. What exactly is the role of the campaign? Is it to give more reason for people to run away from the vaccine, or to actually convince them to get these vaccines? If we are looking at vaccination campaigns in terms of communication, then we are doing it right. But if we are looking at vaccination campaigns in terms of using 5 days to mobilize and vaccinate communities at mass, where there is already hesitancy, this is waste of investment. What I think will make sense in the current landscape in terms of recovery is, rethinking our strategies, making it a little bit more human-centered. We have to go back to the drawing board and ask ourselves, why are we really doing this in the first place? If we are able to respond appropriately to this question, then we'll begin to design strategies that are more human-centered. We cannot talk about, vaccinating children in the sense of preventing epidemics, and then we don't consider communities that are generally missed, even way before the pandemic. And now that we have pandemic and there is hesitancy, we have to acknowledge the fact that as long as there is this hesitancy, we're not going to get the herd immunity, which is the primary reason for which we are vaccinating in the first place. So the first thing is to rethink the approach of investing too much in campaigns which are not sustainable, very expensive, and then usually human resources not usually sufficient to cover missed communities. And that is why each time there is catch-up, the communities that had always missed this vaccination will still be missed. And so we'll keep on talking about this same subject if we don't look at this strategy. Talking about recovery or making progress in the next years, looking at post-pandemic, we have to think about integration. It is the only way forward. If you have a weak community health system, even if the national health system is as strong as what, as long as the primary healthcare system is weak, we will be unable to sustainably vaccinate children, and will continuously need investments from institutions like Gavi to keep up, and yet it will still not be sufficient. So we have to consider integration. I'll take a simple example. If we want to look at HPV vaccines that have also worsened during this pandemic, if we want to ensure that you have sustainable service delivery when it comes to HPV, we have to consider options like providing not just vaccination, but also screening at the same time, right? So we screen for the mother, we're educating the population, and we're vaccinating the girls. So if we look at it from this aspect, then I think we'll begin to make progress. Thank you.
So thank you, Dr. Sangwe. That was indeed very, very powerful. So really two issues that I'm going to pick on. One is this whole issue about whether campaigns and general campaigns, mass campaigns, which are disease-focused, are the right way to get to those children and those communities that are epicenter of disease and disease outbreaks. So who are we catching up on? So that's really the first insight that you shared. And the second is about integration and taking HPV as an example to say, okay, if we are offering vaccination, is there really an opportunity for us to connect that also with screening and treatment of precancerous lesions? Because that is when you begin to really signal to communities that you are truly invested, or institutions of the government are truly invested in their broader health and well-being. So Dr. Saad, let me turn to you to reflect on these two insights of Dr. Sangwe, based on the work that Deepa alluded to. So, the work that you did under I Vaccinate and, looking at different, are there insights there which are speaking to these two key issues that Sangwe raised?
So, look, first of all, campaigns can be helpful, but they're not sufficient. We know that campaigns can be effective in the short to medium term, but campaigns are helpful. They're not the long-term solution. We can't get away with just doing campaigns. We have to invest in routine immunization systems. But routine immunization systems are not just, there are several examples that you alluded to. The time for vaccination, the clinic experience, and some of these other interventions that are not seen as behavioral interventions, but they are very much grounded in those principles. And so therefore, I think whether it's campaigns or routine immunization, I think they have to be together, but they have to be enhanced by a 360-degree perspective on immunization that focuses on both supply side and demand side interventions as overlapping, as complementary parts of a healthy immunization system. The second thing is, of course, vaccines can't be delivered and should not be delivered as a standalone intervention for communities, because that's not how communities experience and see and seek the benefits of a health system. And it should be part of not just a health delivery package, but also a more integrated community development package. So since the pandemic, one of the things that I've done is that I've engaged with several colleagues who are development economists and have increased my focus on thinking through interventions that are delivered together with all sorts of other things. So coming back to what kind of things that we have found that are effective, first of all, when we actually look at it, and others have looked at it, if you look at it systematically, there is one thing that you push back against, which is the perception that there is very little evidence of things that work. No, now increasingly, in the last 5 to 10 years especially, there is reasonable and sufficient quality evidence. The second thing is that there is this perception that there is no evidence from low and middle income countries. That's also incorrect. That goes with the fact that obviously that more of the evidence comes from high income countries, but there is evidence, there is sufficient evidence to warrant evidence-based action from low and middle income countries. Things like vaccine champions, things like the community architecture, the choice architecture within the communities, things like certain kinds of incentives, things like effective messaging, things like various ways of engaging communities, and so on and so forth. Things like focusing on values-based engagement, both at the micro level and at the macro level. The good news is that we are empowered by all the evidence that is out there, but that also puts the responsibility on us to say that that evidence is deployed, that's implemented, that's integrated into whatever we do around vaccination.
Thank you. And let me now turn to Lillyan, because she works in communities on the ground. So therefore, Lillyan, two things that came out of what Saad said. One is, this whole imperative of taking a 360-degree perspective on immunization, bringing supply and demand together. And the second is about integration. How do you deliver an integrated service delivery package to communities in order to enhance their confidence? So you've done it, right? Would you want to share with us some experience around these two issues? The value and how actually in reality that can be carried out.
Thank you very much, and I'm pleased that we are all in this conversation. As a health promotion practitioner in Nairobi, Kenya, Nairobi is cosmopolitan, and we have diverse communities, and so does each and every other country and region. So when we are looking at the 360-degree approach, we must first appreciate the diversity of the communities. And when we are talking about communities, we are not only talking about communities at household level. Communities are people who share same values, same norms, maybe religious beliefs and so on. So we must first understand who are our communities and what are their priorities. One thing that makes immunization a challenge is that if we can just reflect, is immunization the first priority for a family or a caregiver? Then, if it is not, maybe we've just looked at the keynote speech, and we were looking at the vulnerable in the urban, that is the people who are living, like in my country, less than $1 a day. Would they be waking up to go and look for money for food, maybe pay some bills for their children, maybe in school, and so on, shelter, health, because health, it depends on whether it's quality. At times they have to chip in to go for private health services. So when we look at this, what is their priority? So we first need to understand our community and what their priority is. We must also appreciate the strength of the communities. The communities have a lot of resources that we as health services do not tap on. The community also have their own structures. No community doesn't have their own leadership, doesn't have their own way of communication, and other relative approaches that they need to have. So for you to work with communities and for you to have them appreciate the immunization services and at whole the health services, you need to work within their structures. You need to build trust. This morning I was just talking with someone over breakfast and telling them, I'm at county level, at management level, but more than 90% of the time you'll find me in the community. Because I have to understand who am I planning for. I have to do a lot of social listening. At times we want to develop strategies, we want to develop approaches. Have we done any social listening on the ground? For example, if it is the HPV vaccine, do they really know anything about the cervical cancer? Have they seen a survivor? Have they lost someone? If it is the measles campaign, can the community describe for you in their own terms what measles is? Do they know the complications after measles? A good example is when we are doing the polio campaign. Yes, in countries and especially in Africa, people appreciate. But as I grew up, as a young kid, I didn't know anything about polio campaign until I started seeing the posters with people walking with crutches. And I was asking my parents, and this is still vivid in my mind, what happened to these children? Because the pictures that were being shown were for adolescents who are walking with crutches. So for me, I was afraid, does it mean when I get to this age, I too will be walking on crutches? And I kept nagging my parents to tell me the story. And interestingly, my own mother told me one of the uncles lost 5 children suddenly. And the ones who are surviving, 2 of them walk with crutches. She didn't tell me it was polio, but she told me the story. So when I started working and training as a nurse, I understood what polio is. And anytime we have the polio campaign, I'm very passionate to make sure that people realize it was there. It is sort of eliminated in some of the countries, but we still have cases that are suspected and at times confirmed of the same. So the story of polio is not yet over. So if we have to work with communities to realize that they need to embrace vaccination at household level, at individual level, at community level, and globally, we need to look for strategies and approaches using the human-centered design where you touch the hearts, you touch the minds, and then this transits into action. Let us also allow the community to have their own community voices. If we want to tell a good story about vaccination, we could look at someone who has survived from a disease that is preventable and let them be the advocates within their communities. The religious leaders, They earn a lot of trust. They have big followings. Why can't they be our mouthpiece? So when we are looking at strategies and approaches, let us always appreciate the communities. We must also understand that for us to have service delivery that has impact, especially on immunization, are we planning with our communities? Most of the time we are looking at the data, we are looking at desk reviews, we are talking into research, we are looking at our past campaigns, our health system strengthening, but we are not looking at demand. And when I'm saying we are not looking at demand, we are not looking at the consumer. Let us always know that we are duty bearers. For us to deliver the immunization services, we are the duty bearers. But who is the right holder? It is the consumer. And most of all, when we look at the routine immunization, the consumer is the baby, less than 2 years. Do they have a voice? Who is their advocate? Who pitches for their rights? Who talks for them when they are not getting the service? It is only when the advocates from the community resonate with their own community to be the champions, to be the advocates, to even demand for the same services from the ministries of health, then we shall have gone the right direction. I'm very passionate about social media. In fact, when we were being given the keynote speeches, I was quickly into the YouTube channel to check whether it is live and posting on my own WhatsApp, pages. I'm already sending this on social media. We need to look at social media space. During the COVID-19 pandemic, we saw what happened. And even whatever happened in the social media is now affecting our routine immunization. We are having hesitancy for the HPV vaccine. In some places, even for the OCV vaccine, the oral cholera vaccine, we are having hesitancy. Why? Still some communities believe it could be laced with the COVID-19 vaccine. Issues to do with fertility, virility. What are we talking? If the ministries of health and the implementing partners are not going to take the direction of social media, then we are leaving a big gap where anybody, anywhere can fill in their own stories, their own negative stories, and tell things that are very negative and any other vice against immunization. How do we bring the media on board? Yesterday, I saw somewhere in the UK where a bus had a crash and several people lost their lives. I'm not in the UK. I'm in Bangkok, and I was able to see this. So for our vaccination and immunization programs, what are we doing? Are we bringing media on board to tell the good stories? And for us also to do an impactful intervention for vaccination and immunization, we must tell stories. Let the vaccine programs and the ministries stop talking at people. We want you to do this at this time, at this pace. Can we start telling stories? Stories are powerful. Each one of us can remember the stories we had from childhood, some books that we have read. They are still vivid in our mind. And after all, they are very impactful. They make us change our perception. They might even make you change your values and your beliefs. So we will continue with this engagement, and let us also engage in looking at the health promotion space, which is more of preventive promotive, and they are the advocates that also do a lot of public literacy and a lot of health communication. I also would like to ask that let us also look at demand, because if we don't do proper demand creation, then we still miss out in the numbers. Thank you.
So thank you, Lillyan. That was fantastic. So let me just relay what I thought was extremely powerful, right? Let's stop talking at people, right? So this I decide, I tell, I do syndrome and mindset at the global level, at the national level. And so Glenda, to you, my question is, does this resonate with you? And how do we reverse this mindset at the global and the national level of I decide, I tell, I do? And really the second issue that I want to highlight is what Saad said, which is about evidence. That there is evidence, right, from lower middle income countries for, the communities that we're all seeking to serve and support. And to what extent are you seeing evidence being understood, being appreciated, and then traction to action that?
Thanks for that. Can you hear me? So I'm going to use my experience as a researcher in vaccines, and so I'm in my experiences in rolling out antiretrovirals for pregnant women, and then doing HIV vaccine research, trying to ensure that we bring people who are at risk for HIV into a vaccine trial. And also my experience when we ran the COVID vaccine trials, the first program to establish efficacy of these COVID vaccines. So it's about, what happens when you are a researcher and you're trying to show that your vaccine works or has value? And I think, and then looking at it, how you translate that into practice. I think the first thing, and I think most of the people have said that on the podium already, is the issue of trust. We have to build healthcare workers, researchers, the health system has to make sure that people trust us. And often there's a lack of trust because there's issues around minorities and also around the lack of proximity to the interaction between the researcher, the community that you're working within, and the policymakers. So trust is very important, and we have to learn how to build trust. If people don't trust research, they're not going to trust the vaccine that comes from the research. So it's important. And that comes with the importance of communication. And I think most of the panel members have spoken about communication. But the first thing that we do, and what we did with COVID vaccines and some of the HIV vaccine work that I have been involved in, is the importance of stakeholder engagement at every level. And if you want your program to roll out, you have to have engaged with all the stakeholders within your community, whether it's the chief, it's the hospital advisory board, the advocates, everybody is important of doing the stakeholder engagement to ensure that that people see the value of the vaccination program or the value of doing this. And when we started to do COVID vaccine trials in Soweto, we had normally worked with young women, and now suddenly we needed to work with the elderly. And how did we find the elderly? How did we bring them in? How did we engage with them for them, because they were the people that we were targeting to establish the efficacy of the vaccine. And so it required a whole different approach to engaging that community. And we learned a lot. We learned that people don't have reading glasses, so they couldn't do their vaccine report cards. So just in terms of just getting glasses to people so that they can read and understand the work that they have to do. Working in Soweto, people didn't have Gmail accounts. And so basically to upgrade the digital access, as well as providing data, teaching grandmothers how to use data and smartphones is part of the whole engagement that you had to do for something to work. So I think it's important from all of our points of view is to make sure people see the value of vaccination. And I like the idea of the stories that you told, the value. Why should we vaccinate our infants? Why should a mother take antiretroviral therapy? Why should an elderly person take a COVID vaccine or influenza vaccine? So to see the value of the vaccination. I also saw during COVID the importance of the interaction between the researchers, the health policy makers, and the politicians. And that was incredibly important in the time of COVID, is because science for the first time was forefront. And never before had people listened to scientists. And all over the world, we saw people, the community working with scientists. The scientists were the most visible people on television. We started to build trust with scientists and with healthcare workers. And if the policymakers, the politicians, and the scientists don't work together, you can't continue to build the trust. The politicians were the change agents in the COVID vaccine strategy. They stood up. The presidents were sometimes the first people to be vaccinated, our sportsmen. So important to have change agents to make sure that we understand how change occurs and who leads change. So when you're thinking of vaccination programs, it's important to have a woman and her baby together with a politician, together with a sportsman, together with an actress, who all endorse the vaccination, because it's about trust. If you see a soccer player getting vaccinated, or a Bollywood actress, or your president alongside a woman, everyone will understand the importance of and the value of vaccination. Because if we all have to value vaccination, and we see the value of vaccination when presidents and actresses and sportsmen value the vaccination as much as a mother in a rural community. So I think it's important to address the issue we've heard about uneducated women, women in displaced communities, and women that are far away from the centres. And how do you make those women value vaccination? So what we have to create in this area is how to value vaccination, how to give it a price that becomes people want to aspire to be vaccinated. There has to be an element of aspiration, and that's very important for me. And that's what we learned with HIV vaccines, is the value to aspire to participate in an HIV vaccine trial, because you want to be a change agent. You want to be the people that said, I was part of a program that found an HIV vaccine. Other issues around that is the issue of transparency, and we saw this with COVID, is that unless you address the issues of hesitancy, unless you're honest about the side effects, so transparency and honesty, to tell the communities, look, this is the risk-benefit ratio. Yes, this may happen, but it stops you from dying. It stops you from being in hospital. So it's the honest dialogue that we have, and sometimes we're scared to take the community into our confidence. And we're scared that if we tell the community there's a side effect, we're going to create hesitancy. But it's when we're silent and we're not transparent about the side effects is that we alienate the community from us, and we make them scared to take the vaccine. So it's very important for us, to have this continual dialogue, and we had to do this during our COVID vaccine program in South Africa, because people would come on the television and say, I got a stroke, or my father had this big tumor from the vaccine, when we know it was cancer. So I think it's important is that not to shy away from the side effects of vaccines, and to be honest, take your community, take your population, take your country into your confidence and say, yes, this is the risk-benefit. This is why we need you to be vaccinated. I also want to make the point of importance of training healthcare workers on the ground. And you spoke about, so it's about also taking a healthcare worker to understand the value of vaccinations. And that's why it's important to make sure that you don't turn women away when their infants are sick. Just see the value of the vaccination, and that's important. Also, the issue around proximity. The healthcare worker is seen as a trusted member of the community and being proximal to where the participants are. And then I want to also address the issue of being proactive in your communication. So very quickly we saw with COVID how organized the conspiracy theorists were, how organized the anti-vaxxers were. Before we knew it, they were launching court cases around vaccine mandates. Before we knew it, they had an orchestrated media campaign. They were so much more organized than the vaccine advocates. And so we have a lesson to learn. We have to be good communicators. And healthcare workers, we suck, quite frankly, at communicating. And so we have to be as clever as those anti-vaxxers, how they infiltrated the media, how they organized politically, how they got funding to take scientists to court. You know, I've had about 5 court cases where we had to be, the scientists had to be expert witnesses against the anti-vaxxers. So they sent us death threats. They targeted people. So I think we need to be very clever and understand that there are a lot of people with a lot of money that don't believe in vaccines. And we have to understand that they're very clever at managing the population, because people don't trust doctors. They don't trust Western medicine. And so it's very easy for us, for communities to fall into this whole anti-vaxxer campaign. So I do think that we have to learn to be smarter in our communication. We have to learn to be honest. And we have to take the population into our confidence, and we also have to add value, the value of a vaccine. Make it show the value of why it's important to be vaccinated. So those are the lessons I've learned as a scientist, not as a policy maker. Thank you.
So thank you, Glenda. And you, of course, talked about, trust, right? And Deepa, earlier on, you talked about, this being highly volatile and also context-specific, right? And then we also heard how, health workers really are one of the most trusted sources for communities. But for that to happen, they need to have access to accurate information and honest information. So what we know, but what we don't know, and we have to admit that. So, but I think this also requires a lot of flexibility, right? In terms of flexibility, in terms of resources, flexibility in terms of planning and execution. So would you be able to share, how are you thinking about providing that flexibility, not just at the country level, but also at the subnational and the local level, so that the change makers there have the flexibility and the flexible resources to do what is needed?
Yeah, thanks, Anuradha. So I think a very good question on that. So I think once the pandemic was declared over on the 5th of May, as we all know, of course, there is a risk that the risk perception is going to go down, right? But the pandemic, of course, made the whole world come to a standstill in the past 3 years, but also it was also an opportunity in the sense that we did get a lot of resources during the pandemic. So to repurpose some of the funding that we have, even though the pandemic is over, of course there's inequity issues, there are many elderly population, there are immunocompromised people, we still need to continue vaccinating. But at the same time, with the resources we have, what we've been doing, at least from UNICEF and other partners that we are working, is to provide and working with the donors and supporters and all, to have the resources, not just the funding, but also the capacity, the systems that we've built. For example, the COVID-19 funding that we got for COVID-19 vaccination only, that could be used for promoting the routine immunization. That's one very easy, that's a no-brainer, because you've got the resources. You cannot divide communities one day on COVID-19, the other day on PCV, or the other day on nutrition. It's the same family, it's the same child that we are talking about. So to be able to use some of the resources, but also the capacity that we've been able to strengthen during the COVID-19. For example, the cold chain, there was a huge investment in cold chain, the data systems, all the monitoring. So these are some of the things that we really need, are thinking about, not just thinking about. Countries are already using it to have COVID-19 plus, but also integration is a very key thing that we are saying, that while you are still continuing to use the funding for COVID-19, you can still use it for other areas of public health to strengthen the routine immunization. Yes, the catch-up campaign needs to go on because you need to bring the children to the level which was there before 2019. But at the same time, the key is how do you balance the campaigns with the routine immunization. So I think in terms of even the donors, so we are working with the partners to say, can we just come together and align with the national immunization strategy? Because sometimes, not sometimes, often we see that we've got our own mandate and our own way of thinking. But now the partnership, one team, one plan is something that we are really talking about in terms of investment. But lastly, I think in terms of really advocating with our decision makers, with the policy makers, using the data that we have from this, whether it could be State of World Children, it could be WHO, UNICEF estimate of national immunization coverage. This data, the evidence which we've been talking about, can we use it to advocate with the decision makers that they really need to invest in immunization? Because immunization, it's a no-brainer that it's one of the most cost-effective public health intervention, which has got not to do with health, but it saves so much of opportunity cost, because we are protecting children from diseases, which means that the parents would save time from taking care of the children. The children are more likely to go to the school and complete their education. But also as women, if you look at it as a primary caregiver, then she would be not have to spend time away from work. So it is also linked to very much of women empowerment. So all these resources, I think we have to look at it both the preventive side of it, but also look at what is available in terms of resources which we can advocate for. We need to advocate also with the Ministry of Finance. It's not just the Ministry of Health's responsibility. Are we doing enough? So those are some of the thinking that we are saying, moving beyond just this traditional thinking about this is the responsibility of health only. It's not, because we do need to bring other stakeholders, the private sector together, and we have seen so much happening during the COVID-19 which we can learn from and continue supporting the countries to take it forward in terms of innovative financing, strengthening the system, health worker support, and all that.
So thank you. Are we running out of time? And time has flown by, right? How many? 5 minutes? 2 minutes? Okay. So I have to sort of come to all the panelists with one last question, and you can quickly reflect on that. This is about social media. So Lillyan talked about social media, our ability to use digital technologies and particularly digital media. Glenda spoke about sophistication of the anti-vax campaigns and, just then getting ahead in the game. Do you want to, but we've also, on the other hand, heard about the penetration of mobile phones and how sometimes over-reliance on digital technologies can exacerbate inequities and the divide that we already have. So would you want to reflect on this, Dr. Sangwe, a little bit based on your own experience of the extent to which this is going to work, and also the precautions that we need to take? And then I will go to Saad and Lillyan and Glenda very quickly for very brief reflections, please.
Yeah, thank you very much. I think this is very important. If we're able to explore the media the right way, we are going to have the right results. It's interesting because no matter how remote the community is, they give you a story from a media. It could be TV or radio or something, which means, first of all, the communities are aware of what vaccines are. There is just a question of trust, and this is where, the issue is. You have, for countries like Cameroon, the last campaign that they did, they invested a lot in communication, and it yielded enormous results when it comes to COVID-19 vaccination, because they explore all forms of media, calling champions and so on involved. It was not a traditional campaign of focusing more on just mobilization and service delivery, but it was more of communication and then service delivery. So I think it's something that will be useful no matter which community we are looking at.
Yeah, since you sort of framed it in the context of social media, I can tell you that social media, as most of you know, has evolved substantially. The reach has increased. The new type of media that has come along, for example, TikTok, its penetration, Signal, and all of that. For too long, we have brought nail clippers to gunfights. We have been outmatched. And there are a few things this could be group of people can do that are in that hall. Perhaps this is the most concentrated group of people with expertise, talent, and community experience in this field. So it is the responsibility, collectively, those of us who are physically there and some of us who are in spirit there, to continue to talk about general stuff, principles and visions, but get down to the specifics. We need to build trust, but how? What are the things that are working? We need to have community engagement, but how? And what is working, what is not working? We should be intellectually honest about not just trying new things, but evaluating them. We owe it to the communities to make sure that we bring our A game to the fore, because this is not a place where we continue to spend resources ad infinitum on things that perhaps work and perhaps don't. So therefore, we need to gather that experience. And that experience is not just quantitative experience. Just to be clear, good evidence comes in many shapes and sizes, but we know when interventions are deployed, some work, some don't. And coming back to, again, wrapping up with social media itself, that's an example of how we need to increase the skill level of the public health community. And as in collaboration with our colleagues at UNICEF, WHO, Ad Council, and PSI, etc., we were requested by Meta, the parent company of Facebook, whether we could develop a course for ministries of health for large health organizations, etc. So we did. Initially, we had a closed cohort of a little over 100 people from various parts of the world. And then, as in second iteration, we opened up that course as a Coursera freely available course that we will continue to update, proactively engage. And last I checked, as of last week, there were more than 5,000 enrollees, and a ton of them were, already providing response to the kind of practical exercises we had. So the bottom line is, the field is changing; it's evolving fast. We need to rise up and match the moment.
So thank you, Saad, for that. And this is such a beautiful reflection to close our discussion with, that the field is changing, it is evolving rapidly. We need to seize this moment. We need to meet this moment. The focus, as you rightly said, to be on how. So when we are talking about community engagement, building community trust, how do we do that? And Lillyan spoke to that, saying, it is important to understand, appreciate, acknowledge, respect community priorities, so that global priorities are more in sync with community priorities, but also working through community structures. So when we are talking about trust, who is it that communities really trust? Who is that person? And how do we invest in that person in order to make sure that we are able to, through that person, really reach and build the trust of communities? So I'm mindful of the time. I'm going to pause this discussion here, but actually hand over to Eva for a very quick question answer this thing, if we have some time, because I'm sure people have a lot of questions to ask of panelists. And Eva, do we have time for a quick Q&A? Okay, all right. So let's see what is on the mind of our audience here, and they may have. So depending on the excellent reflections by the panelists, if people have more questions, then here is the panel to respond to them.
Yes, and please state your name and affiliation.
Good morning. Thank you for this interesting panel discussion. I'm Sheetal Sharma, from a senior immunization advisor from Core Group. I was reflecting on some of the points you made. When I was growing up, all my immunization was done at school. Secondly, coming into Thailand, you have to bring your ratty yellow fever certificate, which also at the back I put my COVID stamp. And in Kenya, I sat on the National Task Force for vaccines. So the reason I'm bringing up these points is, you said it, we're bringing in Ministry of Finance, Education, the school sector, because in any community, there's a church or a mosque, a school, and a health center, including the caregivers. So what's the intersection as we're going forward with possibility of integration funding, and multi-sectorial and multi-level approach? So what is the junction now in 2023 on to 2024? We're talking about these multi-approaches, but also thinking about historical successes that we've had in immunization. Thank you.
So Eva, do you want to take one or two more questions and then, turn to the panelists so that they can be responded to in the same?
Thank you so much for great discussions. My name is Ridwan. I'm working with UNICEF Pro. One thing that I also take some note is, why people turn to social media, because they don't have anyone to trust to at the community level. And I do still remember when I was graduated as a medical doctor, I was basically go to the community, but I don't have any background or even skill to do communications. So what can we do? Because this is something very important. What can we do to equip them to go to community? Because one of my time, I remember that I don't have enough time to educate them. And there are no push as well from the policy that I need to report about communication. It's all about numbers. When I try to invest my time more in educating the reports say, please give us a number of children how to vaccinate. So that's a very conflicting moment for health workers. I still remember that story. So I think one thing I want to take from the panels here is like, what can we do to invest on equipping those health workers to have a better communication or better time to be able to educate those community. Thank you.
Thanks so much. Professor Margie Danshan from Murdoch Children's Research Institute in Australia. Thank you for a fabulous discussion. I just wanted to get the panel's opinion, I suppose, on at the World Health Assembly, it was very clear that Dr. Tedros highlighted the global shortage of healthcare workers that we're going to be experiencing up to 2020, and just the need to use more diverse community advocates. Glenda, you touched on the fact that, it's really important to have diverse people standing up promoting vaccination, from sports stars to Bollywood actresses, to mothers and children. But the problem is, I think just having those people standing up is not enough. I think we need to help equip them to be more purposeful change agents and advocates in their communities. And I just wondered if you'd had experiences with that or doing that in communities.
Thank you. I am Ralph Midi from UNICEF Regional Office for Latin America and the Caribbean. I really want to thank you for this powerful introduction this morning and all the rich information from the panel. My concern is thinking of low and middle income country and the inequity that exists in all those countries. I have been very, how can I say that, lot of thought to see how I can bring the immunization agenda as a priority. And someone mentioned the link between immunization and community development. And for me, I find it very, very hard to do. So I would like to extend, the conversation to you, because I'm coming from a region where we see the majority of zero dose in those areas like in Brazil, the Amazon, among migrants, where, they are neglected, by politicians. So how we bring that into the political agenda, and so that we change the current situation, using maybe immunization as the avenue, to improve communities' life. Thank you.
I think I'll take one more. Go over here.
Hello, everyone. I'm Ekapa Dashwili. I'm a professor currently representing as a regional partner of Results for Development. But previously, I remember the meetings of Sabin Vaccine Institute. I represented Sabin Vaccine Institute to the European region, and we had most focus on sustainable immunization financing and vaccine advocacy. But now we see the evolution of success of immunization programs. Now we see that 99% of coverage, it's not enough, and we still see the backsliding in immunization coverage, particularly after the pandemic. So the question is, we have so many effort to immunization programs. We train doctors, we buy vaccines, but currently we may think about the voice of trained doctors too. So do they translate their knowledge into the practice? And how the organizations where they learn, where they work, provide this learning opportunity for them to use their knowledge for the best. For example, we frequently dismiss the role of managers. Do primary healthcare managers provide enough support to immunization to cover all the zero-dose children? So I think that we still need to think about organizational cultures at the primary healthcare level. And my question would be if the international society, the partners represented here, has any idea how to apply to this project and how to apply to this problem, because everything happens at the organizational level. Thank you.
So I think we now 6 minutes, 30 seconds and counting down. So please, if each speaker wants to answer one of the 4 questions we have.
Sure. I'll start off with the communication strategy. So when we started the COVID vaccine enrollment, we knew who we had to focus on. We knew who were at risk for severe COVID infection and what we needed to do. And so we had a very sophisticated communication strategy, which involved Twitter, involved community radio, it involved television, Facebook, and this was to get minority groups, old people who couldn't even read, into our programs. And so it was a very successful campaign because we managed to hit everything from billboards to Twitter to community radio. So we went on community radio. We had conversations in taxis, commuter bus taxis in our country. We engaged with taxi drivers, and so it has to be a multi-sectorial approach to your communication strategy. It has to be very sophisticated, but it has to reach everybody. Which gets me to one thing that's missing in this vaccine program. It's just the voice of men. You know, when we saw the pictures, we hear about the uneducated woman, we hear about the displaced mom and child. But where's the voice of the grandfather, the uncle, the father, the brother, the male sibling? You know, where are men in the immunization program? They're missing. You know, we just see everything. It's always the woman's fault that her child is not vaccinated. And we kind of neglect it and we ignore men and we don't bring men in. Men are very trusted in our communities, and we need to engage men to support the vaccine execution in our communities.
Thank you. Maybe I'd want to talk about the space in communication and what we normally do as Ministry of Health and our implementing partners is to give statements. Statements are not conversations. And that is why I said we need to look into the space. Even the anti-vaxxers, they were telling stories. They were not making statements. They told stories and then they gave key messages. The problem is that in health, we give statements and give directions and give policy guidelines. So we need to revamp the communication space. Most of the people who are maybe employed or deployed to do communication are people who have done international relations and mass communication, very different from health communication. I know I've been supported by mostly UNICEF and WHO to bring me experts to help me work in the health promotion space. But once they get into the conversation, they've also learned a lot from us who are not experts, but who have value of social listening while working. We understand the structures in the community. We are the people who listen to their perceptions. We are the people who listen to what they need to be done now or to be done when and how it should be done. So even when we are developing the communication strategies, developing our communication plans, I'm seeing a lot of us going to support the mainstream media. Are we looking at the traditional media? Are we looking at how a community communicates amongst them? Because I've seen most of the communication being put just before the news item or after a news agenda. And I'm happy you're talking about men. I really do bring men in all my working spaces. If you want to give attention to anything health for men, why are we not investing on some messages during the Super League? I know all the men here are affiliated to a certain football club. Are we investing there? For me in Nairobi, I'm working very closely with the boda riders, with the matatu operators, and most of them are champions in health. So we need to look at when we are saying health communication, what do we mean? It is not giving directives, it's not giving statements. Thank you.
Very quickly, thank you, Sheetal and Ridwan, for two questions. I'll just very quickly reflect on that. So, Sheetal, you asked about integration. What is the thinking going forward? I think that as social and behavior change or demand promotion people, we do not look at only one channel of communication, and it depends so much on what is available and what are the credible sources of information. So yes, the religious leaders, the youth champions, the women's group, whatever is available, and to have the maximum intensive efforts in having a dialogue, as Lillyan said, using the human-centered design approach to make sure that they are engaged. We are not telling them, we are really engaging with them to co-create local solutions. So Ministry of Education for HPV, a must. Local development, women welfare, whatever is there. So we would need to take it forward, not just as a health issue, as I said in my comment before, but more as an integrated approach, as a community development approach. So that's the thinking that we'd be taking forward. And very quickly to Ridwan. Yeah, it is a challenge that our health system does not pick up our data on social behavior change. It's an ongoing thing. We have tried in many countries, including my own country, Nepal, to include one or two indicators in the health system. While we work towards that, I think we also need to be very serious, and even if it's outside the system, we do need to invest in the systems to look at social data on a regular basis, not ad hoc, and use those evidence to then co-create solutions with the local communities and build the capacity, because you did bring a thing about do they know how to communicate as health workers. in many cases, we are investing, as you know, as UNICEF and UWH and other partners to develop the competency of the health workers, but not just training after training. It does have to have a supportive supervision with it. Are the health workers being paid? Can we mobilize some of the social mobilizers to support the health workers? It's not just a one of IPC training that we are looking at. So I think that we'll just have to be creative about how we do things. Thanks so much.
Thank you. Just to talk about building trust with healthcare workers, there are 3 key things that we should look at. And the first step has to do with assessing the quality of vaccination from community perspective, and then leveraging these findings to do onboarding, continuous learning, and supportive supervision. So if we take this into consideration, then we can begin to build trust. And then talking about how to develop integrated packages to involve community development. This can only work from a bottom-top approach and not the other way around, because this has to be context-specific. We have to use objective tools like the community-oriented primary healthcare model to decide what the community truly needs without us, deciding on behalf of the community. Thank you.
Saad has the final word.
Sure. So a couple of things briefly. So one of the things that were pointed out is health, the relative importance of social media and healthcare workers. For example, it was phrased that people go to social media because there is some gap in trust. So we have been measuring this over 20 years in various communities using various tools. Turns out that those who vaccinate themselves or others, or who are eligible for vaccination, if you look at them, the most trusted source of vaccine information remains the healthcare provider, irrespective of the population, irrespective of the situation. The second and third varies. And those who do not really are not very gung-ho about vaccines, even for them, while they have lower trust in healthcare providers compared to those who do vaccinate, but even for them, their level of trust is the highest in any source, which is healthcare providers. So compared to all the other sources, it's the healthcare providers that they trust the most in. As those of us, or many of us, are engaged in programs, and these kinds of things, if you are truly listening to communities, and communities individually and collectively are telling us that they trust healthcare providers. So in terms of resources that need to go into, for example, programs that empower healthcare workers, there is this gap. There is a skills gap. We have measured it, others have measured it, in terms of how to effectively communicate. Even though the community trusts them, the tools are not out there. The good news is that there have been packages that have been tried. There have been approaches that have been tried, and they seem to be helpful. For example, motivational interviewing and its different shades. It doesn't work everywhere, but it's a useful thing. Presumptive communications in certain situations. Package interventions like Sky that has been tried in Australia, and hopefully it will be tried in low-income countries. But there are others that have experience of training healthcare workers in places like Pakistan, etc., that has been helpful in truly responding to what the community has been telling us, that they trust the healthcare providers. So it needs to go in with these upskilling of approaches, but also resources. Yes, the resources have doubled and tripled, but they started with minuscule. And 4 times minuscule is not a high amount. And if your comparison group, if your counterfactual is what was spent before, compared to what component of total spending on vaccination is social, behavioral, and cultural interventions and community engagement, it still remains minuscule. So if our vulnerabilities are coming from this side, our response should match that vulnerability. And the last thing I will say, it was brought up that there should be sort of different kind of players that could be engaged. All I'll say is we all need more Bollywood in our lives.
this brings us to an end of this keynote session. So please join me for a warm round of applause for our keynote speaker. Special thanks to the Sabin teams who make this possible. So Stacy, Kate, Meredith, Teresa, Brian, and Nick, thank you so much. A few housekeeping, coffees outside this room, and there will be 3 concurrent sessions starting sharp at 11 in this room and the 2 other rooms. Thank you.